Hello, and thanks for watching this short, but I think important presentation entitled The Six Faces of Dissociation. I'm going to explain how the term dissociation describes six significantly different phenomena and how this situation does not serve us, but only causes confusion and misunderstanding. I am Mark Cornfield, a somewhat retired psychiatrist whose career shifted into the psychedelic world in 2017. And since then, my focus has been the use of ketamine for mental health. So why am I doing this? And why does this issue even matter? Well, as a psychiatrist whose career has recently focused almost exclusively on the use of ketamine to treat mental health issues, I have, not surprisingly, found myself taking a special interest in the word and the concept dissociation. You see, ketamine has always been and still is classified as a dissociative anesthetic, and therefore it is reasonable to assume that a person's impression of ketamine could well be influenced, and likely negatively, by the associations they carry with the word and concept of dissociation. What I will demonstrate in this presentation, as I have said, is that the same word dissociation actually describes these six significantly different mental processes, and that by applying the same term to these processes, we cause significant confusion and misunderstanding amongst mental health practitioners and their patients. It paints with the same brush, and usually a negative one, six very different processes whose usefulness to the individual can range from dysfunctional to neutral to impressively positive and helpful. Further, it gives many people, including many mental health professionals, an almost automatic bias against and wariness about ketamine because of its label as a dissociative medication. I am now going to show you a list of the six faces of dissociation before I go into a brief explanation of each one. Dissociation number 1, absent-mindedness. Number 2, trauma-related dissociation. Number 3, dissociative identity disorder. Number 4, the experience of someone on a relational or psycholytic that is a low dose of ketamine. Number 5, the experience of someone on a somewhat higher dose of ketamine, which we call the transformational or psychedelic dose. And finally, the sixth face, which is anesthetic ketamine. But before we look at these individual phenomena, let's have a look at the word and meaning of dissociation itself. The word dissociation is a combination of the word association, which means connection between things or people, and the prefix dis, which means not, or the opposite. Thus, for example, we have appear and disappear. Therefore, dissociation is the state of affairs which occurs when things that are normally connected become disconnected. In the realm of mental health, we are usually referring to disconnections between aspects of our cognitive, emotive, intentional, or sensory function that are normally connected. To some degree, disconnection is the case in all six of the following phenomena, and yet all six are significantly different and have very different implications, ranging from problematic to potentially very helpful. Should they all be given the same name? I don't think so, but they are. So let us now look in more detail at all six of these phenomena. So as you can see, the first dissociation is something we call absent-mindedness. We have likely all had the experience of setting out to drive to one location, say the grocery store, but at some point, we become aware that our mind has been wandering, and we have actually driven ourselves to, say, our place of work. This phenomenon is sometimes given as an example of how we are all capable of dissociation in everyday life. It's a version of dissociation that is only a minor problem, and can and does happen to anyone. It is instructive that the term absent-minded is applied to this situation. It is a recognition that the mind has been absent or disconnected from its usual connection to our intentionality. We don't usually think of this as dissociation, but it clearly is dissociation, and that term is sometimes applied to it. The second phenomenon, trauma-related dissociation, is the one most commonly referenced in the realm of mental health, and it's what tends to come to mind when therapists hear the word dissociation. It is viewed as something worrisome that should be moved away from as soon as possible. It usually has its origins in severe childhood trauma. If a powerless child is being abused by a powerful adult, the defense of fight or flight is rarely available, and so the child's nervous system resorts to the freeze response. The freeze response is usually understood as a response of the physical body, but most of us are aware that the mind participates in the freeze response by finding a way to go away, to be elsewhere. That is, a way of not being cognitively or emotionally present during the abuse. This disconnection or dissociation is a remarkably useful and adaptive response during the abuse, but later in life, it can become problematic. This going away response can take over in the here and now, if something in the present is similar enough to the original trauma to trigger an alarm response. The body shifts into the freeze mode, while the mind disconnects from present reality, becoming absent from the present moment and unavailable to the people who inhabit it. Therapists are trained to recognize when their clients dissociate in this way, and they employ what are called grounding techniques to help reconnect the client to the reality of the present moment. Trauma-based dissociation, which was so helpful to the child, has become problematic for the adult. Now, given that therapists tend to be most aware of this particular dissociation, this trauma-related dissociation, and given that they are usually doing their best to prevent it, it makes sense that they would be highly unlikely to be receptive to any medicine, such as ketamine, known to cause dissociation. They might be equally unreceptive to the idea that there are phenomena which are also called dissociation that can be helpful, positive, even healing. The third dissociation is the mental behavior of those people who are given the diagnosis of dissociative identity disorder, or DID. This is not a going away, as in absent-mindedness or as in the freeze response. It is rather a shift in the dynamics between inner parts of the psyche. It is increasingly accepted, for example, in ego state work, Gestalt therapy, and internal family systems, that the psyche can be understood as having various ego states or parts. DID is an amazing phenomenon that allowed clients who have it to survive the most traumatic of childhoods. Now, when a person with DID dissociates, they are not absent, nor have they gone away. Instead, the part of the psyche that is usually connected to the environment and guiding the client's behavior becomes disconnected from what we might call the steering wheel that directs the person's inner and outer worlds. And it is replaced by a different inner part that feels an urgent need to deal with whatever the currently evolving situation might be. This dissociation is quite different than the first two dissociative phenomenon I have described. Now, the next two phases of dissociation involve the use of a lower or relational or psycholytic dose of ketamine and a higher or transformational or psychedelic dose of ketamine. Before I elaborate about these two phases of dissociation, it's important that I include a caveat about their use. I am going to describe some of the potential benefits of the use of ketamine, but I need you viewers to be aware that the benefits described are only likely to occur in the context of a secure therapeutic relationship between a well-trained and experienced provider and the client. Proper and adequate preparation for the ketamine experience. Experienced guide presence during the ketamine experience. And finally, skilled integration following the experience. These are very important. So let us turn to dissociation number 4. This dissociation is the mental experience of someone under the influence of a low dose of a dissociative medicine, such as ketamine. It is often called the relational or psycholytic dose. The disconnection here is that the low dose of ketamine seems to provide a degree of separation from, and therefore increased perspective on, one's usual, often obsessive mind. Low-dose ketamine moves the user instead into what might be called witness consciousness or observing ego. From this perspective, this fourth phenomenon called dissociation, the person tends to neutrally notice and not be controlled by their defensive armoring, their fears, their emotions, etc. In this state, they tend to be less defensive, less rigid, and instead, they are more open, more honest, more flexible, and more empathic. This provides the user of relational dose ketamine with a profound opportunity to learn about themselves, to take new risks, and to make positive changes in how they cope in their inner and outer worlds. This is not a dissociation to be avoided or interrupted, but a highly desirable and potentially healing state. My partner, Susan McBride, and I are particularly enthused about the relational dose of ketamine as a lubricant to relational therapies, and we have used it to facilitate couples therapy. On the next slide, I share just a few of the comments made when we asked our clients, what difference did low-dose ketamine make to how you engaged in couples therapy? And this is what they said, verbatim, some of them. For the first time in my life, a freedom to feel the feelings and think the thoughts with nothing intervening. Very different. Ego separation. My ego usually gets me by the throat. Ketamine is a tool to open up, reduce defenses, listen in a safe place. Along with the facilitation and imago dialogue, ketamine enhances the ability to open up and empathize. It allows you to live in the impulsiveness of your brain, be more spontaneous, less censored. It allows me to overrule my own defenses. The answers just come up. There's fewer filters, more permission to be transparent. Ketamine makes you take your mask off. So I hope you can see the potential therapeutic advantages of working with relational dose ketamine and the particular version of dissociation that it produces. Dissociation number 5 is the mental experience of a person under the influence of a higher, but still some sub-anesthetic dose of a dissociative medicine such as ketamine. This is often called the transformational or psychedelic dose. Higher dose ketamine causes a more profound separation, not only from usual mind, but also from our bodily senses, and even the experience of being in our body. There is often a sense of separation from one's usual self or from the ego, But despite this, there remains what one might call an observing presence, which can remember and work with the experience. I want to talk a bit about brain connectivity. On this higher dose of ketamine, there is much more connectivity within and between areas of the brain, and that is what this slide illustrates. What you are seeing on the slide is the result of neuroimaging studies that measure and illustrate the degree of brain connectivity. The outer portions of each circle represent regions of the brain, while the curved lines within each circle represent connections between brain regions. On the left is the normal state of the brain. And on the right, we see the remarkable state of hyperconnectivity when patients are given a psychedelic, in this case, psilocybin. The difference is dramatic and speaks for itself. Now, in this dramatically increased connectivity in the brain, in that state, the recipient is no longer available to here and now reality. They're gone. But they are exponentially more available to aspects of experience that would normally be unavailable. These so-called psychedelic experiences can include access to archetypal, cosmic, and mystical realms. Again, this is not a dissociation to be avoided, but one that can be highly desirable and even life-changing in a very positive way. It is with this final phenomenon, dissociative anesthesia, that we finally arrive at the so-called dissociative anesthetic, which ketamine is officially classified as. Under an anesthetic dose of ketamine, the disconnection from both mind and body is so utterly profound that the recipient is no longer receiving information from any of his or her senses and is totally out of touch with all aspects of the outer world. There is no longer an observing presence to remark upon and remember whatever might be going on in the inner world, if anything is. The recipient is anesthetized, but not by the same process as most anesthetics, which are extremely sedating. Ketamine, by contrast, is actually a stimulant and therefore a much safer anesthetic. It achieves the effect of anesthesia by extreme dissociation. So those are the 6 phases of dissociation. I am listing them again for you to read to yourself. I hope I have made the case that they are quite different, and that our field would be much better off if these differences were better understood. So, do I believe that by making this little presentation, I'm going to have any significant influence on the manner in which the term dissociation is used and understood? Do I really think that there's going to be a committee struck that will erase the term dissociation and invent 6 new terms that will more accurately and specifically identify the 6 different phenomena? Well, that would be nice, but no, I don't really believe it. But I do hope that you who see this presentation will be much more aware of all the nuances possible when you use or hear the term dissociation, and that you no longer see it as a monolithic concept. I really hope you will encourage others inside and outside the ketamine community to see this presentation. And then perhaps, just maybe, it may eventually be easier to be a provider of or a beneficiary of ketamine, the dissociative anesthetic.